Hello, all. This is Dr. Red Ounside with Jack Pardo in Chile. Hey, Jack, where in Chile are you?
I live in Santiago de Chile, is the main city of my country. Maybe almost half of the population of the country lives in this part of Chile.
Well, if you guys don't know, Jack is one of the most prominent cosmetic gynecologists for the past 20 years. Probably the guy in Latin America that led this all before anyone else was doing this. In my earliest memory, I can't find anyone else who had started this way back in the 90s or early 2000s. I was seeing your name everywhere. So, hey, Jack, so give us all a background on yourself. Tell us about how you got to this field. And after that, we really want to know how you got into labia majora work, because this is going to be part of an interview I'm going to use to write a little bit of history for labia majora.
Thank you, Red. Well, I have to come back to my beginnings in medicine. When I was a very young boy and I wanted to be a doctor, I always wanted to be a plastic surgeon, always. But when I was in the fourth year of medicine, I became in love with gynecology, but but always I have in my mind the plastic surgery. And when I began the residency in obstetric and gynecology, I was very surprised, and it was a shock for me what happens with the vagina of women after the deliveries. And I always thought that it was not normal this and let women to be like this after delivery. So I always try to do my periodotomies during when I was an obstetrician. I know that this is not correct now, but I always perform a medial periodotomy because it was something more aesthetic and more functional for me. I never was scared for the anal sphincter because I knew how to repair it. And fortunately, in all my story, I don't have patient that I did a delivery with anal incontinence, but it was absolutely different if you compare the result after a periodotomy or episiotomy. It's different. One day, and in 25 years ago, a patient that I performed a delivery asked me to tighten her after 2 years. And I did it without thinking that this is going to be something regular in my patient. And one day I saw a TV show in my country talking about vaginal rejuvenation. That time I was working in the most important private center in Santiago de Chile, a very beautiful and a big hospital, private, Clínica Las Condes, and I searched in internet and I found just one name in that time, David Matlock, David Matlock, David Matlock.
That must have
And
been
I
around
2003.
2002, 2003. Yes.
Yes. So I sent an email to David Matlock asking him telling him that was a doctor from Chile, 41 years old, that I wanted to learn about it. And David returned, came back immediately in minutes and told me, "Yeah, Dr. Pardo, no problem. This is going to be a pleasure for me. You have to pay, wow, and a big amount of money."
Yes, we all know how
Yes.
much that is.
Yes, in that time, it was for me a very big amount of money. So I told him that I had a laser. I didn't, at that time, Red, I didn't know what David did with the laser. Nobody of us know. I thought in my imagination that he was doing with the laser something that years later was with the intravaginal laser the real laser rejuvenation.
Right,
But
the fractional lasers
yes,
of the
yes. At
current
that time,
time
I
now.
thought something like this, but I wrote him. I said, David, I had a laser in my clinic, an erbium laser. I don't know if it is correct, but uh, maybe you should only teach me and not sell me the laser. And he said, yes, okay. And I present this project, this idea to the board of the clinic, and they give me a scholarship, a half scholarship to go to with David. And I went in September 2003 to do my training, my one almost one because there was a French guy. He was not. It was almost one-to-one training with David. With David, and at that time I had I would say an important experience in vaginal and gynecological surgery because I worked as a gynecologist in oncology in a public hospital with big cases for maybe 6-7 years, and I
We
was
have, Jack, we have pretty similar backgrounds because I was doing gyn-onc in my
yes.
past also. So we
Yes,
had exposure to
I
labial
know that,
surgery.
and the oncology gives you skills for surgery, and then I quit oncology because I'm returning some 2 years before with my partner Vicente Solá. We inaugurate the pelvic floor department in Clínica Las Condes, unit in Clínica Las Condes. And then I thought that the combination of urogynecology and aesthetic and functional gynecology was perfect. And that's why the board of the clinic took seriously this. So I went with David, and in this trip to LA, it was very interesting. David he's very serious when he teach you, very serious. He takes this in a very professional way. If you have to say some jokes and laugh something, is after the course. During the course, Davis is a guy extremely professional and serious, and he give us a theoric base of this, and then we practice. We practice. I know that this is going to be more oriented to labiaplasty, but the course was oriented to vaginal rejuvenation. But during the course, he told us that he's going to teach us something that is going to the phrase. I'm quoting David. I'm going to teach you something that you're going to do more than vaginal rejuvenation. Is the labiaplasty. At that time in my life, perhaps I done maybe 2 or 3 without any discipline. So he teaches us how to use the laser with a hair of a pig to a laboratory way to do it, to use the laser. And
It was a 980 diode laser.
980 diode laser, yes. And then we went to the OR, and he performed vaginal rejuvenation, perineoplasty, vaginal rejuvenation that we called on that time vaginal rejuvenation, the corpoperineoplasty in a woman without a prolapse. So after that, in some of the patients, he performed labiaplasty, a beautiful labiaplasty. He's a very, very good surgeon. So this is the beginning of the story. And in the same trip, as I was in US, I went to Atlanta to see John Miklos and Robert Moore, how they
Sure,
were
sure.
Yes, they work, and the story is very amusing because they received me there, and this Chilean young doctor, and they asked me one day, "You're coming directly from Santiago, Chile," and I was very ashamed to tell them the truth because they were very famous in the at yoga, and yoga something like this would be seen as very bad, and I was
Yes, yes,
ashamed.
it was politically not a good thing to do
No,
cosmetics
absolutely
then.
politically incorrect to tell anybody that you went with David Matlock, and I was very ashamed. I told them, "No, I went to LA to learn something." They said, "What? What?" Well, I'm a little bit ashamed of this, but I went with David Matlock. No, I can't believe you, David Matlock. He's very famous, but what does he do? What is? And I signed
Non-disclosure.
a non-disclosure document, so it was a very uncomfortable situation. Now I can say all the story, I showed them all the videos. I told them everything, and I encouraged them to go with David. And at the end, I was right because after me, the 3 days where I was with them in Atlanta, they decided to go with David Matlock, and they became members of the Vaginal Rejuvenation Institute, and they are also one of the pioneers of vaginal of this discipline in all the world.
Right, and
So
they have maintained their close friendship for decades now. Those guys have really supported each other.
yes, absolutely. And then I came back to Santiago de Chile, and I began to do this surgery in the private hospital. The first 10 surgeries were with no profit pro bono. And after 10 surgeries, the general manager of the general director, medical director of the clinic said to me, "Well, now you know how to do it. You must begin to do the business." And the clinic support me in a communicational point of view, and they arrange me in interviews with TV and other medias, and I began to do a lot of surgeries.
So you had a lot of marketing support from
A
your
lot at
institution.
a lot. I was in the most important TV show at night in Chile. It was a TV show of medical TV show. I performed surgeries with interviews of the patient, and I became a very known physician in Chile, very known. Now,
You were like a Beverly Hills 90210 doctor.
yes, proportionally in Chile, I was
Yeah.
something like this. And but what happened? Can you imagine? All the rest of my colleagues in Clínica Las Condes and in the area of pelvic floor in Chile became absolutely upset and jealous of me. It was something very difficult, very difficult. At that time, fortunately, we were with my partner, we were the pioneers also in urogynecology in Chile using the vaginal meshes. We were supported by, I was a speaker of AMS in Chile, and my partner was speaker of Gynecare. So we have all the most important. So that was a way to compensate the fact that we done also aesthetic surgery, aesthetic vaginal surgery. But it was very difficult. The rest of the doctors went to the medical director saying that there was no any clinical evidence to do this. It was inconceivable that Clínica Las Condes supports someone that do these surgeries. But I was a very important guy for the institution because there was a lot of money involved, a lot of patients. Until one day it happened something. I give an interview for an important newspaper, and the journalist asked me about what if I know something about the G spot, and I told her that I don't do the G spot. I didn't do the G spot at that time, but I know what it was about it, and I prefer not to talk because I was not giving giving that procedure to my patient, and she asked me to tell the story of the G spot, but off the record. And I was younger, and I was more innocent than I am now. I told about the G spot because I knew two patients with David that had the G spot, and they told me that it was fantastic. One of the patients told me that she had 20 orgasms. I tell the story to the journalist.
Now, David had just started teaching
Yes,
that shot there because I saw the advertisements just come out.
yes,
So you were
2020.
one of the very first to learn that.
The first, one of the first, yes. And I told this to the journalists, and they wrote a full page of the newspaper telling that top gynecologists will bring to Chile injection that will give you 20 orgasms.
Oh no!
And wow.
Now the
And
doctors got really
no,
mad.
no, they wanted they were older than me, gynecologists that went to the board of the clinic, asked asked them to fire me from the clinic. And the general manager, the medical director, they said to them, "This is something that we are going to manage," and they sent me to the honor. There is a like a they sent me to a judgment by a tribunal,
Is it like a medical board
a medical board, a ethic medical board.
for the government or for the
No, for
oh
internal
internal? Okay,
of the
okay.
clinic. Yes,
How,
but
by the way, how big is that clinic? Give us an idea.
an idea is
Doctors.
for, at that time, if 400 beds, and yes, 400 beds. I would say very luxury at that time, and all the medical specialties, even
How many
all,
OBGYNs like you?
at that time, maybe 30,
So
30,
30 of your colleagues were not happy with you.
uh, 25 at least.
25.
Yes, very unhappy with me. So after the final decision of that board of all doctors of all specialties, internal medic, pediatrician, etc., they said that I was not. It was so innocent to do that an interview in the rest of the time. Every interview that I give to the media must be under the supervision of the journalist of the clinic. Well, I think that it was okay.
That
And
sounds
that
fair.
time, yes, absolutely fair. And that time it happened something that changed my life. It happens that the medical director that he loves that surgery, he loved it. And he always said, still at this moment, it's our project of vaginal surgery. He's a nephrologist. And he was, after that, 10 years later, he became general health minister of health in Chile.
Wow.
Yes. And he said to me this, for all the people I said this story, there is nothing written in the literature about this. You must write something, even for there is a book for children in Chile that is in the newspaper, and he told even for this review.
For this children's book.
Yes, even for but you must do some paper. Otherwise, this is going to be something impossible for the rest of the time. And that time, I began to collect my first patient, my first 50 patients of vaginal rejuvenation, and with a young doctor that I bring. It was my resident of the hospital. I bring him to the Clínica Las Condes.
So at this time, you were teaching in academia also.
Yes, I also, at that time, I was a instructor of vaginal surgery at University in Chile in a public hospital. I have very big privilege. I went only only Mondays. I did the surgery. I teach and some theoretical classes. I never did polyclinics, big numbers of patients. All this, the thing was prepared for me to do surgeries Monday morning. And that time I did many vaginal measures called suspensions to the sacrum, etc., etc. That kind of surgeries. So I wrote the paper named Colpoperineoplasty for women with a sensation of a wide vagina. And
I've read that.
Yes, yes. Everybody of you have read that paper. It's in the books now. That paper is in the bibliography of all the books, the textbook. And I was so, again, naive that I sent this paper to the Gray Journal, to the American Journal of Obstetrics and Gynecology.
Oh my goodness.
Oh my God.
That's impossible.
Read. They sent me a review of three pages telling me that I was a disaster. And the last sentence was, I will never forget it, instead of bad investigation, it's better no investigation.
They just wanted to bury their heads in the sand.
Yes. I sorry, but
Do you remember who the reviewers were?
No, I don't remember. But I remember the last sentence. And then I thought at this moment, where is people that do good obstetric and gynecology and that open mind? Where are they? And I remember, I remember some image in my mind. I said, where is Sweden? Is Norway? And I remember that journal, the Acta Obstetrica Gynecologica Scandinavica.
Yes.
This is a top 5 in obstetric OB/GYN, but also they are open mind. And I sent the paper to them, and I told them the truth that the paper has been rejected by the Great Journal, and in less than 3 weeks, they answered me, your paper is fantastic, we're going to publish with any correction. Any.
None.
Wow.
One. That's impossible.
Even though they sent me, I did some statistical analysis, but the results were so good that they sent to me, it is not necessary to put, we're going to erase the statistical analysis because you have more than 90% of patient satisfaction. So it's stupid but they made any correction, even in no English correction, nothing, absolutely nothing. And the paper was published, and then some people began to communicate with me. The first one was a guy from Barcelona, Dr. Xavier Arcusa, that he wanted to invite me to Barcelona to teach vaginal rejuvenation. And then all the story began. The first invitation was him in Europe, and then Congress, Marco Pelosi began to invite me to their meetings.
Like in Las Vegas.
Yes,
I remember meeting you there.
Yes, Las Vegas. And also the next year, the 2007, I published the first laser labioplasty paper. You know, for many of people that are seeing this video, they must say, oh, but David Matlock was doing this 10 years before, or this guy was doing labiaplasty 10 years before, or 20. But we know that if you don't publish, it doesn't exist.
It never happened.
It never happened. So the first paper of vaginal correction in a woman without prolapse, just for sexual uh, target, is the paper that I wrote. And the first labioplasty paper with laser is mine also. So these two
Well,
papers,
David purposely avoided publishing anything because he had a teaching
yes,
program
at
that did not
the
want
first,
anyone to know
I want to say,
specific techniques.
yes, I want to say that at the first moment, David communicated with me, and he was a little bit upset with me. And I explained, David, if you continue to manage this as if you are a middle-aged wizard, nobody will take you seriously. We must open this. This surgery must be done by people that know how to do it, but we must communicate that we do this seriously. The other people that were very upset with me, and after that they recognized that they were wrong, is John Miklos.
John does not like even my teaching program way back then. He always said, "Red, why are you teaching other competitors?"
Yes,
John never liked my teaching also. But he's remained a good friend.
John, I'm talking about John. I love him very much. John is my friend.
We all do.
Yes, he has been in my house in Chile.
Oh,
so, yes. The last year when we did the Congress in Chile, he went to a dinner in my house. So John is my friend. But at the first time, he was very upset with this. But I think modestly that the first person who opened this to the general public was me, because before me there were many people doing this, but nobody wrote a paper in a serious journal.
Right. I was similar to David. I didn't want to write papers about my radio frequency techniques, and I didn't even speak about it in congresses till about 2006 or 7. I just didn't want to tell anyone.
Yes. And after me, all of you realized that, hey, he's communicating this, but only you don't learn how to do something reading. It's not enough. You must to have a train. You must to be in a training program. Yes, the hands-on is very important. Even if you see, if you have a lot of experience in vaginal surgery, for sure you're gonna learn in 2-3 days. You're gonna learn, but you're gonna learn how to do it perfectly. No, because I've been in this for 20 years, and still now, when I sit in front of a patient with a labia hypertrophy, a big labia hypertrophy, and also mixed in with a vaginal scar, it's a challenge for me every day. I've been doing this for 20 years, and I have a challenge every week.
Yeah.
It's
I can relate, because when I finish mine, I says, "Oh, I look at my brain later on. I could have done this different." Yeah.
Yes. It's very exceptional that I took surgery for something easy. I don't do that. I'm always concerned about the surgery.
That's amazing. That's a great story. Now, what happened then in your
what happened then, and very important. It's very. What happened then is that this medical director became, is very important, Minister of Health in Chile in the government of Sebastián Piñera. It happens 14 years ago. I knew that if that man left Clínica Las Condes, my days in that institution
were numbered.
Were numbered, absolutely. And it was true. 1 year later, it it was a very bad year, very, very terrible year.
What year was that?
Uh, I know he was in the government, but there was another medical director, and all those the gynecologist and the medical director they really bullying me.
Do you remember the exact year?
Yes, absolutely. It was 2011 to 2012. And in 2012, they fired me from the clinic. They fired me without any medical complication, without any ethical issue, without nothing. The reason was the medical directors, the reason he said that I cannot afford more pressure of your colleagues.
Wow, he buckled.
I cannot. It's impossible for me to afford more pressure that I have to. So they fired me from the clinic, a clinic that I was a member of the. I have stocks of the clinic. It's a private center.
So they fired you without any real justification. It was just pressure from your partners.
Any.
Wow.
You know, I want to make some. Santiago de Chile, the people from the upper class, economic upper class in Chile is a little bit small. So in Chile, what happens in a clinic like this, it's known by everybody. So if you have a bad case for a patient with a complication and someone fired you from the clinic for something like this, or there is something medical legal issue, in Chile, everybody knows when something like this happens. And never someone said something like this about me, because everyone knows in Chile that I was fired because of the jealousy of other doctors.
Wow.
Everybody knows. No one, there is no one person that said he was fired because he had a complication, because
or incompetence.
No. Nobody has said something like this about me. So I was fired. It was I will confess that I cried like a baby in my house. It was terrible. This was the place where I wanted to work since I had I don't know 20 years. When the clinic that clinic was founded, I wanted to work in that place. So I was fired, and I began to work in a small clinic, a boutique clinic, where I began to do all my surgeries, even incontinence, prolapse, and aesthetic vaginal surgeries, that clinic. And I began to have a lot of success very, very quick. The first month, I had 7 surgeries, and from them, I had every month, 15 surgeries, 18 surgeries. So it was very good.
So everyone was coming to see you.
Yes, absolutely. They come to see me, and then it happens another breaking point. The next breaking point is when I went to Las Vegas and to Pelosi's meeting.
I saw you, where I met you.
Yes. That year, we have a picture with all of us. Yes, and that year, a young guy from Venezuela approached me. At that time, he was bigger than now, Jorge Gaviria.
Oh, Jorge, yes.
And Jorge Gaviria began to talk to me and he taught me as a professor, I want to know you. You are my hero. I read all your papers. At that time, I had a lot of papers because I wrote papers also as an abstract for yoga or also for the for many congress. I have many papers about
your core, because your core was pelvic surgery. You were a pelvic surgeon. You weren't just a labial surgeon. You were a pelvic surgeon.
Yes, of course. And he approached me and said, I want to know you, and the people from Venezuela, they give me the money to come here, scholarship to come here, just because I told them that you were coming and I will be with you. I will be your friend. And he talked to me. I want to introduce you something that I'm doing. And at that, it was at the night that he talked to me about a vaginal laser that introduced in the vagina, and we were with some drinks, and he never connect well what he was talking about. And the next day he explained that he had a laser that rejuvenate the vagina internally without surgery. And I found I thought of this me. And imagine this 10 years before.
Right.
And then there is a guy.
That was the birth of the Mona Lisa and the
Yes,
photon systems. Yes, they were all
yes,
getting born then.
yes. And then he invited me to to give lectures to Caracas in Venezuela when it was a normal country.
Yes, yes.
Yes, and we had a very great time, and I was the main lecturer invited, and he connected me with people from of Fotona
Yes,
people.
Fotona. With
And
Byzantine Zdenko.
Marcelo Tetamanti.
Yes, yes, yes.
Yes, and I don't know how they reached to do this, but they sent me. It was a lot of money, and they sent me my first laser in 2000 December 2012, and I received it in May 2013 in that boutique clinic that where I was working.
By the way, you didn't mention when you were fired, how did you get back on your feet again? And how did you end up with your new clinic? Tell us that story.
No, the story is that I went first to a small medical center with people that know me from the medical school, and some of them were internists or etc. And there was a lot of gynecologists that one of them was a very close friend, and he take me. I will care of you. They were very nice people.
So it was a competing medical group.
Yes, very, very, very good people. Yes, very serious. And I began to work there. And then it happens that the owner of a boutique clinic where they have the facilities to do surgeries, she called me. I don't know why, and because, to talk about a patient, I don't know, but and she said it would be great that you can work someday in my clinic, but you are in clinical Ascon. I say, hey, I was fired. Oh, come here, and I went. This woman she's a nurse, but she's the daughter of the owner of this clinic, and she's a very smart, and we have a meeting for 8 hours.
Wow.
8 hours working, and we designed a program of pelvic floor and vaginal and anesthetic and cosmetic gynecology in that institution.
Were they going to get you your laser back, or you had to buy all new stuff?
At that time, I didn't have any knowledge about the vaginal laser. It was 6 months before.
No, your diode laser for vaginal rejuvenation.
I didn't have a diode laser. The diode laser was in it was in Clinical Las Condes, and I do the surgeries. I began at that time doing the surgeries with
standard cautery.
Yes, standard and the red tip, the one what we call the
Colorado tip.
The Colorado tip. But 2 years later, or the next year, I bought a diode laser, a small diode laser from China. So and then I went to that clinic, and I acquired the Fotona vaginal laser, and I began to do lasers to my patient. They were very happy, and in 2016, I published one of the first series in. There were some papers in lasers journals, in aesthetic journals, but there were no one paper of of the treatment of urinary stress incontinence with laser in an
No.
obstetric and gynecology journal.
Right. The articles that Gaviria and Gaspar were writing
Yes.
for GSM mostly.
Yes, those are we must recognize that those journals have compromised interests because there are journals related with the industry. So I'm not saying that there are bad papers. I'm saying that it's not the same to publish in those journals than in journals that are only academics. So I wrote a paper about treatment of urinary stress incontinence with laser, and I sent it to the European Journal of Obstetric and Gynecology. That is a very good journal, very good journal. And they accept this journal, this paper, and I went to the yoga meeting in 2000. It was in 2015. In 2016, I went
In
to
South
the yoga meeting.
Africa.
No, before that, in Nice, in France. And when I was in France, Willy Davila approached me in a bar. He knows me before
Who
by
did?
name.
Who was it?
Willy Davila.
Oh,
Willy
Willie.
Davila.
Willie
Yes,
Davila.
Davila, yes. You know him.
I know Willie. Yes, of
Yes,
course.
he's a extremely very famous urogynecologist and important in yoga, very important in yoga.
Right. He's in Florida now.
Yes, I know, in Cleveland Clinic, I think. Yes, and Willie Davila approached to me in that bar, and we had a drink, and he was the president or the past president, just the past president of yoga, and said, Jack, the cosmetic, and we know you. We in the board of yoga, we know you, and we think that cosmetic gynecology is something that we cannot stop. It arrives to stay, and we want you to create the cosmetic gynecology special interest group.
Yes, I remember that. I remember when you were building that.
Wow, I couldn't believe that. I was at that time I was nobody, and I create this, and the next years I did some breakfast with the expert. Two workshops in yoga where I invited John Miklos, Robert Moore, Oscar Aguirre, Adrian Gaspar, etc. And I think that I was the one who brought cosmetic gynecology to yoga, and now yoga.
They still have a special interest group run by a new fellow out in Newport Beach.
And so I'm very proud that yoga for the first time they saw and seriously cosmetic gynecology was with me, and that's the story. And coming back, one anecdote of the story is that Clínica Las Condes, the institution when I was fired, I sent my stocks of the clinic in 12 years ago at the best price they ever had, ever.
That's fantastic.
Believe me, it was an important amount of money. Important. It was, you can buy a good house with this. And now, 12 years later, these stocks worth maybe 25% of the price of that time, because the clinic is just it is going to be break it in some months. It's something happened. It's not to talk with this with who. It's not the reason to talk about it now, but the fact that for young people that is seeing this, when a door is closed for you, you must see that there is an open window there.
Right.
And something big is open for you. You must be very optimistic. I come from a family that my grandparents parents came from escaping from the Nazism, the Nazis in Europe, and you always have to be, if you have health and you have your hands and your mind, you must continue your path because there is always light after the tunnel.
Right. When the Lord closes a door, he opens another one.
Yes, it's true, absolutely true. The most important favor that someone made for me in my life was when they fired me from Clínica Las Condes.
I was going to ask you that. Probably, I was wondering in retrospect, that must have been a highlight, starting point of a career.
In my career, the most important thing that happened was when they fired me from that institution.
It gave you freedom.
Yes, absolutely.
That's an amazing story. Boy, our lives parallel each other a little bit. Now tell me specifically then about the labia majora. How did you start working with that? Because I know David did not teach labia majoroplasty. He taught a expanded perineoplasty to pull the majora down. So how did you come up with that idea?
Yeah, the story of the labia majora is like this. I have in my experience when I was maybe in the 100 labiaplasty, a woman came to my office and said to me, "Doctor, I need a labiaplasty." And she went to the examination room and I saw her, but your labia are normal. No, doctor, not that labia, that labia. And she showed me the labia majora. And she asked me, "You know how to do this?" And I told her, I will be sincerely with you. I don't like to patients. I don't like to lie. So I told her, Mrs., I never done one before, but I am grandson and son of tailors. So believe me. Yes, believe me. And it's true. My grandfather and my father were tailors, and they working with clothes. And I said, I can do it. And she trusted me, and I did my first labia majora, and I put the name, lifting of the labia majora.
I saw when you were calling it labia majora lifting.
See, I called that, and now everybody called it like this. And
what year? What do you remember? Do you recall when that was?
When I had, I think maybe 20 labia majora lifting, we wrote the paper and sent it to the American Journal of Cosmetic Surgery, and it was
You'll have to send me a PDF of that.
Yes, of course. I will send after the meeting, after this Zoom, I will send you.
When did you do your first one, and when did you get that published? Those are landmark times. I did the first one in 2009, I think, and it was published in 2011. Ah, okay.
Yes, 2 years
Those are
ago.
landmark dates and articles.
Yes, absolutely, because they are the first. I am very proud to say that there are 5 issues that I was the first to publish: the colpoperineoplasty, vaginal without prolapse, labiaplasty, laser labiaplasty, lifting of labia majora, the one of incontinence in a OB/GYN journal. And also I have something that you don't know, Red.
Tell me.
I wrote a case report communication, the only one in the world, of a patient that at the same time had an oncology surgery for cervical carcinoma stage 1 and also labiaplasty and vaginal rejuvenation.
Oh my goodness. So she had a rad hiss and then you went and did your stuff.
Yes.
Oh my goodness.
She was a patient that I delivered her the last baby, and 6 months later, I didn't like the pap smear was normal, but I didn't like the how looks the cervix, and I say, pap, no, normal pap smear, but I don't like how it looks. And I took a biopsy, and it was cervical carcinoma, adenocarcinoma.
Stage one.
Stage one. At that time, I was not a member of the oncology staff. I was in the pelvic floor staff. I took her to the oncology meeting that they have it once a week.
Tumor board.
Yes, and they agreed that it was a patient after all the staging was a patient to do a radical hysterectomy.
Abdominal, rad his.
Abdominal.
Okay.
And but that time the patient said, okay, the patient was a very smart woman. It was a sexologist, a psychologist and a specialist in sexology. And she said, okay, you can do this, but I also want a labiaplasty and a vaginal tightening, vaginal. And they said, no, lady, you cannot have this. And she said, why? Because nobody have done this before. So what's the problem? And we agree this. I was the second surgeon of the surgery. I helped as a second surgeon for the radical hysterectomy, and then we send the lymph nodes, and we send the lymph nodes to the biopsy at the moment, current to the biopsy, and they inform us that the lymph nodes were negative.
So the rapid frozen section was negative.
Yeah, a rapid frozen section, and then we finished the radical hysterectomy, and then we closed, and I did vaginal colpoperineoplasty and also labiaplasty.
That's fantastic. And you published it?
Yes, of course, it's published. I will also send it to you.
Yeah, I'd love to get all your articles. I'll put a collection of Jack Pardo highlights.
Yes, I will send it to you.
That's fantastic. Now, okay, so you did that, and then tell me, when you first did your labia majoroplasty, what technique did you use at that time, and how did you know what to do? You reviewed your oncology articles?
It was only my plastic anesthetic point of view. Nobody teach me that. I remember in my practice in oncology was very little in vulvar oncology. Chile, at the times I worked, was a country with a lot of cervical cancer and of course endometrial, ovary, but in vulvar I didn't have a lot of not a lot. I didn't have experience, but
you had enough experience, anatomy knowledge to know that plasty work didn't have big vessels there to hurt.
No big vessels, and then I put the patient stay in and this I made the traction of the labia. This is what you have to remove, and then I imagine the drawing like a lozenge draw,
like a football.
Yeah. Like your football ball.
Yeah, yes. US football, like Senior Pelosi used to do.
Yes, more like I would say more like a banana.
A banana.
Like a banana, not symmetrical. The internal is shorter than the external line.
Right.
Yes, and then I began to do it, and what that was important to tell is that maybe the first 6 cases, I had cellulitis infection.
Cellulitis.
Yes, and I began to give antibiotics, strong antibiotics to all the patients, and it quit. Is this because this is a place with the follicles, and the follicles have bacteria?
The hair, right?
The hair, yes. And that's why all that patient, I give 1 week of antibiotic cefadroxil, and I never had that problem again.
Because the technique you would be doing, the banana incisions, would be on the majora where there's hair bearing.
Yes,
Right. It wasn't more medial
No,
past.
it's no. The medial is medial. It's near the intersection of the labia minora and labia majora. This is where I end the internal
The
portion.
internal one, you put it as close to the minora as possible.
Yes. One thing very important is that my opinion is if you have to do labia majora and labia minora in the same patient, always you must do majora first.
I agree.
Nobody teach you that, but I learned it because I modestly I think I invented for myself the technique. I noticed that when you do a labia majora, a labia minora first, and you do after the labia majora, the labia minora became too short. Many
It
times
disappears.
they disappears. So you always must to do the labia majora first.
Boy, we were doing the same thing one continent away.
Yes, yes, because it is logic.
Yes, 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 yes. So we were paralleling. That's fantastic. And then any early complications under the cellulitis? I'll tell you mine.
No, maybe some descents, but little descents that I don't have to put stitches.
Right.
They repair spontaneously, but no other complication. I think that labia majora is a more is you must. It's more easy to expect the results with labia majora. Labia minora is a more complex surgery.
I agree. Labia minora is the toughest thing we do. Majora is
Yes,
pretty easy. But
yes.
one thing early on I realized that when I was too aggressive on doing a labia majora, I would have a gaping opening because I took out too much.
Oh yes, of course.
Yeah,
Of
so I
course.
had to modify it not to remove so much that the opening
Yes.
would stay closed. That's what I
Well,
did early
in
on.
in all the plastic surgeries, less is better. If you the overcorrection of everything, you it's very difficult to repair. But if you do an less correction, you can
Yeah.
repair. You always can remove more. But when you remove too much, it's very difficult to correct.
No.
So when a patient came to me for labia minora repair, for example, the most important, if the previous surgeon left a lot of tissue. If he left a lot, it's very easy to do it, to
Right,
repair.
right.
But if
Now, there's a lot of
yes,
misconceptions about complications and things like that. So let's compare notes. Any hematomas?
in labia majora,
Majora.
no one,
Me
never.
too.
I never had an hematoma in labia minora. I had one important hematoma in a 14 years old teenager. It was one of the first that I done with local anesthesia. It was solved the day after with here with local anesthesia, and it was important. And after that, I had maybe 2 or 3 small hematomas with no need to important correction.
More like bruising, because I get bruising. I get a lot of bruising, but I don't get
Yes,
hematomas.
yes, but I had one hematoma, real hematoma. I had one. I think that you have seen it in one of my presentation. He's like this.
Yeah, yeah, yeah. Well, I did. The only time I had a hematoma with was when I did someone had done a Bartholin excision, and the lady came to see me for a labiaplasty. I did her labiaplasty, but her Bartholins blew up. It became a hematoma, and I had to drain it. But it was from another excision of a Bartholin cyst.
Yes.
Now, what about you said you give everyone antibiotics? So I haven't seen any cellulitis or hair infections, but on your early one, you thought you had either a cellulitis or a folliculitis of some kind.
Maybe it's not necessary to do it.
Mhm.
Maybe. But since I have 3, 4 during my first 10, I was afraid. So now for me is routine to give those antibiotics, and I don't want to try to do to see what happens now if I don't do it, because nothing happens if you do an antibiotic for 1 week.
Tell me some other historical things that you think are important in terms of labiaplasty surgery and majoroplasty surgery there in your country. And how did you teach people there? Did you start your own training program? I know I've seen you around the world speaking.
After last year in April, I was president of the first Chilean Congress of Cosmetic Gynecology. We invited, we had many good cosmetic gynecology that attend here, and we have 100 people learning this. But fortunately for me, unfortunately for them, people in Chile are not prepared mentally to spend money in their training. You, me, we are absolutely, we know that to learn, we have to invest. I invest money when I went with David Matlock. I invest money going the first time to all the Congress. Well, fortunately, now when somebody want me in a Congress, they invite me. But sometimes, and you know, Red, I paid my ticket to go to a Congress where I will be a lecturer, and even I will teach someone. Even in that moment, sometimes I pay my air flight ticket.
Right. So what I've noticed, tell me if I'm right, the culture in Latin America does not like to pay for education.
The culture in Latin America, they think that in like the traditional medicine, that we are obligated to teach them this because we have the Hippocrates swear. You know that?
Right.
And they don't understand that this is something different. I'm not teaching someone to do a vaginal hysterectomy. This is when I was in a hospital. I was instructor of vaginal surgery, but this is different. I invest not only money, time, heart, brain in this. Now I have my own clinic, and I advertise that I teach people, and few people has come here to attend Chilean to attend a training program with me. And
they seem to feel that it should be your duty to teach it for free.
I teach, yes.
An academic duty, like you're a professor, and this is all
in a university,
common knowledge, and not something that's like a business or something.
Yes.
Investment.
And the fact is that in Chile now, because of me, there are many people that they say that they do cosmetic gynecology, and I see every day that they say, but they don't do it.
Or they have no training or experience to back that up.
No, I never seen I can count with the one fingers people that I would say they had some training to cosmetic gynecology in Chile. Of course, one of them, you know him, is Ivan Ortega, a very close friend and protege of Marco Pelosi. Maybe Vicente Solar, who has been trained by me all my life, and maybe two more. And most of them, the people, they advertise that they are cosmetic gynecology, and I have never seen one of them in the meetings that you and me we're going.
No, you're pretty. Other than Ortega, you're the only one that actually shows up. You're the one that shows up most of the time on the big meetings. You're always there.
There is no one, never another Chilean, but Ivan Ortega sometimes in Pelosi So is the only, maybe the only one. So what happens is that sometimes they compete with me, charging much lesser money than I. This is the way they compete with me. And how I know that? Because those women, they came with me after they had bad
Yeah,
results.
you get to fix things.
Yes, yes. I know that because they came to me and they had poor results in surgery and sometimes poor results in laser treatment, because the laser I manage, you know it, it's a very, very good
Oh,
device.
you have a Cyton Diva. You probably
Yes,
have
the
the only
Diva.
one in Latin America, because that's
No,
not a
no,
cheap
no.
device
The,
for a
in Chile,
gynecologist.
in Chile, there are 3 divas,
Ah,
but I
okay.
am the only gynecologist that have that owns a diva. The other divas are owned by plastic centers where they acquired the diva because they thought that if they have the patients and if they have the device, they can do a lot of divas, and that's not true, because the divas must be indicated by hopefully a urogynecologist.
Right,
You
right.
must understand how the physiopathology of the stress incontinence happens, and in that way you can understand why the diva works and why sometimes it will not work. Because
Patient selection.
yes, in the last 2 patients that I had in here in my office, in the labs, we were 2 patients with urinary incontinence that I didn't indicate them diva. I indicate mesh,
A
medial
sling.
rectal sling. Yes, because diva is expensive. In Chile, I charge approximately $2,000 approximately for the 3 sessions. And if the patient, for example, the patient has a good health insurance, also a complementary insurance for the other insurance, if I do medial rectal sling and all colpoperineoplasty, if I charge good, they will spend less money than one treatment with Diva,
And be happier because of the
and be
proven
and be
result.
happier because it's forever. So, nevertheless, I will tell you something. Since 4 months, I have one of the most important TV women in Chile from the last 40 years is influencer of my clinic.
Mhm.
She's a TV star in Chile. She's a woman of 65 years old, and I did a diva for her, and she spoke to everyone
Oh, it
on
worked for her
TV,
good.
and she's very happy. And I did a diva for vaginal laxitude and for atrophia, not for incontinence, and she's extremely happy. You know how many sessions of diva it's done in my clinic each month? More than 50.
Wow, that's a heavy use.
Yes, I am the #1 provider of diva all over the world.
Wow.
Say, I've been awarded by Cyton for that. And this was awarded 2 years ago when I did half of the number of diva that I do now. Now,
How do you get him into your office? What is your marketing approach?
I work is I sponsor a TV show in prime time, where twice a week they spoke about my clinic and me in 1 minute. Also, that TV show, that TV women star, 3 appearance. She put maybe one history and 2 reels each month. And also, I have important work in social media, Instagram,
Yes, yes,
and
yes, yes, yes.
of course, Facebook.
What
But
what is your Instagram handle for our audience here?
my Instagram,
Yeah, how do we find you on Instagram? Is it just Jack Pardo MD
no,
or
no, 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 no. I have three. There are. I have my own, my
yes,
personal and
your
private
personal,
Instagram is Jack Pardo, where I upload things with my granddaughters, some
right?
things, the golf and singing, some stuff like this. And I have arroba Jack slash Pardo. Also, I have an Instagram of the clinic. My clinic name is Gyn-Esthetica, like gynecology and aesthetic. And these are two Instagram that I have.
Gyn-Esthetica, yeah.
Yes, and also it's very important. We must never forget the website. Website is very important, very important. My advice to young gynecologists, the cosmetic gynecologists, they must have a website because for me, in the last 20 years, I was one of the first physicians that have a website in Chile. Before me, or when I began, the other doctors, they look with very bad eyes, a doctor with a website. But for me, with the website, it has been tremendously important for the number of patients.
You have a great website. I'll make sure everyone finds this, gyn-esthetica.cl.
Yes, Gyn-Esthetica is the website of my clinic. And also
Right,
I have mine that is urogynecologia, like urogynecology.
right.
That's CL. This is my website.
I'll find it. I'll find it. That's your
Yes,
private one.
yes. Not private, if of my own. The other is Gyn-Esthetica, the clinic.
Okay, I see your clinic one, but your private one isn't popping up. So I'll find it a little bit later.
It's in Spanish. Uroginecología. Yes, for me, this site has been very important. Still now that I have social media, that I have advertising on TV, 35, 40% of my patients, they came here because of Google that sent them to my website.
Ah, that's good for our young doctors to know. Our young doctors
Yes,
are usually quite good in social media and make us older guys look really bad.
yes, yes.
Now,
But as you know, Red, you will agree with me. All of this success is a lot of work. It's a lot of work. When some doctors are playing golf, I play golf, but we have meetings every week with social media managing people. Every week, 1.5 hours. What we're gonna upload this, and then they come here, they take photos, they take a video also. So it's a lot of work.
you know what I have noticed is that our Latin doctors, our young Latin doctors, are very heavily into social media. The Brazilians, I could not believe it. A couple of their prominent cosmetic gynecology doctors, the females, the males don't do it, but the female
Yes,
doctors have a team, one or two or three people following them all over the world. I haven't seen that on any of the
yes.
male
For example, you
doctors.
see the social media of Tina Battaglia, for example.
Right,
She's
right.
wonderful,
Yeah, she's
superstar
fantastic
social media.
right. She's wonderful at it. And another one from, I can't remember what country she's from, but some of the Argentines are really great at it too.
Yes, of course.
Yeah. And so, I really have to hand it to our Latin doctors because they are way generations ahead in social media compared to our European doctors, compared to our most of the Asian doctors. Although some of the Asian doctors I've seen, for example, from Thailand and India are really getting quite good in their social media.
I will give you an example, very interesting. There is a country in Europe that it's zero cosmetic gynecology, zero. France. Nobody in France. Have you been in a congress, in a meeting in France?
Only
Never.
only for MCAS, and they sometimes have
Yes, but
really tiny little meetings.
INCAS is aesthetic, not
Right, right.
cosmetic gynecology.
Right, right.
But the history is that when I went with David Matlock to do my training, the other guy was a French doctor, and
Benjamin
he
Asher?
French gynecologist.
Who was
Yes.
that?
I don't want to say the name, but because
But I know, yeah, I think I know who you're talking about.
he learned the same that me. He was a gynecologist with very good experience in vaginal surgery. He come back to France and he has never done anything in cosmetic gynecology because France is a country that the old physicians they look very bad at this. And for example, and as we know, for example, Alex Bader that runs the ISAC, he has wanted to do something in Paris all life, but has been difficult. France is a difficult country, but in the other side, Latin America, it's very open in this. Chile is more difficult, but Brazil is very open. Colombia, Venezuela is very.
Yeah, those are really good. And
very
even
good people.
the fast growing areas are Central America too, with Mexico and remember in Guatemala they had that big
Guatemala, the Congress, and also, for example, Dominican Republic. They are the first Latin American doctors trained by David Matlock were from Dominican Republic.
That's fantastic. You know, I do know of one French doctor who's a gynecologist in Bordeaux, Hichem Bensmal. I'm going to visit him this summer.
Yes, I know him. I know him.
Yes.
Yes, but it's not the guy that I'm talking about. It's the other one that he never appeared with cosmetic gynecology.
Right.
He spent money. He was trained by David and never appeared. When we interact our Zoom, I remember a little story about we talked before. When I published the first paper, David Matlock, I told you that he was a little bit upset the first time, but few months later, he called me and said, "Jack, would you mind if in some meetings I go and have a place to show my institute? I show your paper."
That's great.
Yes, he asked me to use my paper for his own profit. I told him, "Hey, David, I would be proud of it." And
honored.
Papers are something public. So the thing changed after they noticed that my paper gives more support for the surgery. You know, after the paper, you can do something published, something like this. And David said, yes, there is a paper, and he can show the paper.
Yes. And now you started it, and now there are several out there. Even Miklos wrote a paper, remember? Him and they've written a couple of them.
I remember those
vaginal
papers.
Rejuvenation.
Yes.
So I think you started that. You were the first brave one to actually write about it, while all of us were trying to keep it secret.
Yes, you also wrote.
We were
now
like
you write books.
Yeah. Now we write books, and I have my whole Gynflix where all my videos of 20 years are available.
Yes.
But our original thinking was pretty what do you call it, medieval. We were like the Chamberlains who were hiding how to use forceps. You know,
yes, I always use that story as an example. The brothers Chamberlains, that they covered themselves to do a forceps, and of course we cannot. We know, Red we, at the end of the day, we cannot forget why we study medicine.
Yeah,
We
to
wanted
advance
to
knowledge.
yes, we wanted to study medicine, but because when we were child, we wanted to help people. So we must, at the end, we must teach.
Right, right, right.
But if
Now,
we sacrifice, if we have a big sacrifice in time and economics, we must hope that people also made little sacrifice.
right.
Before, when you and me we began with this, there were no meetings, no
No.
meetings. Now you can go to a meeting and see all the surgeries in beautiful videos and spend money like this to learn.
Yeah.
It's
Instead
different
of what
from
we did, we all trained and spent that much more.
yes, yes, absolutely.
Now, for some reason, I thought your original technique was the American football incision that gave us those railroad tracks, but I think that's the Pelosi technique. If I remember the pictures, the original pictures where there's football
Yes,
shapes removed.
I show you something.
Okay.
Pelosi originally asked another technique. Pelosi used, I will show you because I remember.
Yeah, tell us your recollection because this is going to go under the history section of our book.
Okay, Pelosi do something like this.
Like, oh, sideways, not up and
Yes,
down. Oh.
the first I saw the pictures. The first were like this, and I use two incisions. This is my technique, basically.
Right. Which is more like,
and the inner is very close to the more I can hit the scar, I use it medially, not in the middle, because women will not accept a scar in the middle. The more medial you do the incision, the inter incision is better.
right. I agree with you because you can hide the incisions there and it's almost impossible to find once it's all healed up.
Yes.
Right.
Yes.
That's good. The one picture I do have from Marco he sent me was a football shape marking an incision. I'll find it and I'll send it to you. And it was a football shape
yes,
this way,
like this,
and then he closed it this way.
Yes, but this is the second one. The
that was part two.
He did was like this.
Okay.
I'm talking about 10 years ago. It was like this.
Right. I get it.
I'm sure Marco, he's a brain very fast. He learns very fast. So if he noticed that, he changed maybe very
modified it right away. Now, those are brilliant refinements that you did. How did you choose your patients? I know the first one you said asked you to do it on the majora. She had small minora, but how did you market it and how did you choose the future patients?
Well, as you can see I have a website where it's absolutely discriminate the different surgeries I do. And also in my videos in Instagram, I teach people that there is a difference between labia majora and labia minora. So most of the people that come here to my clinic and my office, they know exactly what they want.
They know the difference.
Yes, and sometimes in my questionnaire that I do to all the patients, I don't try to invent a surgery to a patient that doesn't want or need something. I am very concerned about to not create a problem to a patient that don't have the problem. You know what I mean? If the patient
if don't add it to their brain to get worried about.
Exactly. I could not sleep well if I do that.
Yeah.
So if a patient came to me, for example, for stress, all the patient, I asked them before they go to the examination room, I ask what I call my 3-4 Jack Pardo's questionnaire. Always, always, if they have urinary leakage, incontinence, always, do you feel the vagina big? Do you feel you have an aesthetical problem in your genitalia and don't like? This is before I see them. If the patient
Also,
answer,
they check it and they know that those are the things that
yes,
need to fix.
I ask this to the patient. If the patient said to me that they have no concern about the aesthetic of the genitalia, even if I see that the labia are big, I don't mention.
Mhm. Yes, yes.
I don't mention.
That's ethical.
Yes, I don't mention. I have patients that I delivered their babies 20 years ago, 25, and they still coming to me for their annual evaluation. And some of them have big labia, and they know what I do because I am very known in Chile about this. And also, many of them I saw them socially. They are
Yeah.
friends.
Yeah.
They are friends wise, so I see them socially, and some of them have big labia minora and they don't care about it, and maybe the husband love it, and I take the pap smear and I don't even talk about it.
Don't say a thing.
And this is the way we must act. But on the other side, we must give the information in the way that the patient take the decision of something happened to her and there is a solution for her.
Now, where do you think our specialty is going? Because around the world, I think slowly the accreditation of cosmetic gynecology will increase. It's already a part of the Philippine OBGYN Society and also of the Indian OBGYN Society. They consider it similar to maternal fetal medicine or urogynecology. And I think it's going to happen outside the US. US, I think it won't ever happen for a long time. Perhaps it's a little slow and there's a lot of resistance in the US even 20 years later. But
yes,
do you see that happening in Latin America and other places where it's going to get more accepted as part of a subspecialty?
Yes, because, for example, in Argentina, there are the Argentine Society of OB/GYN. They are inviting people that you and me, we know them, Adrian or Jorge Elias, etc., to talk in their Congress. These things had happened also in Venezuela, in, I think, maybe in Colombia. And in Chile, for example, the Congress that I did last year was academically sponsored by the Chilean Society of Obstetric and Gynecology. This is only the first step.
Those are huge.
But yes, what I think is going to happen in the future, I think maybe I will be not working, I will be retired.
You and me.
Yes, in 10 years, is that I think that cosmetic gynecology should be part of the urogynecologist field.
I feel the same way. I think it matches perfect there.
As, for example, in the specialties in surgery, you have a gastric or abdominal surgeon, you have a maxillofacial surgeon, and you have a plastic surgeon. And the plastic surgeon do also reconstructive surgery, repairing surgery. Who should be the best to repair the vulva and the vagina? I think is the urogynecologist that also in one day, the laser will be accepted. One day, the radio frequency will be accepted, and also the PRP, etc., etc. And who will use this? Not the perinatologist, not the reproductive specialist, and the oncologist. No, why not the oncologist? Because the oncologists have a disclosure. They are always thinking about dead. They only care. Yes, the oncologists only think about the death of the patient. They never think about the quality of life of the patient.
Or cosmetics, because I was a GYN-onc fellow
Never.
before. Yeah.
Never. For example, have you many of women that have an hysterectomy, for oncology hysterectomy for cervix cancer, the oncologists, they never care after some years that the ovaries they fail, and they even don't know that you can give hormones to a woman that had an hysterectomy for cervical cancer, and they only care the woman for breast cancer, for example. They never think that you can give them testosterone.
Right.
You and me, you know that
we always give it. Yeah.
Yes. And the implant of the pellet of testosterone for women with breast cancer is fantastic for them.
Yeah, lowers recurrence.
For example, to make vaginal laser for women with breast cancer is fabulous. You can change the life, but they are not sent by the oncologist. So the vagina is the field for me, for the urogynecologist. For me in the future, I think that in a residency and training program of the 3-year fellowship of urogynecology, I hope that someday there will be 6 months of cosmetic gynecology.
So you don't think it'll ever become part of a general OBGYN residency, or even if a month of exposure?
Yes, absolutely. If you to a general OB-GYN residency, you must teach them, show them all, and they should have maybe 2 months of appreciation to.
Or they could choose their elective time to pursue.
For example, I've been 3 times doctors in a residency in the fellowship of general OB-GYN have come with me to the elective. They can choose.
Right.
They choose one, and I have shown them 2 months of cosmetic gynecology. But it was many years before. Now we have much more things to show. We have now all the PRP. For example, we have the exosomes.
Right.
It's now we have.
Where do you think the innovation is coming from? For example, all the new biologics, regenerative therapies. Where do you see those arising from? I see them arising, yes, in the US for probably the basic science, but the application and rapid assimilation is happening in places like India and Latin America.
We know that evidence-based medicine is sometimes an obstacle for progress. Many physicians that are academics that works in university with teaching program in every area of medicine, they have a mental obsession with the evidence-based 3 procedures. Under this situation, I would never done in my country a colpoperineoplasty in a woman without a prolapse. Never. Or never introduce a laser into the vagina, and they still want evidence-based 3. So
I think part of the problem is that they think only their evidence-based medicine counts and not the evidence-based medicine from other countries that perhaps they feel are inferior in science.
yes, I told them some of them, you will never have this evidence. Why? Because for this, you need the double-blind study, and in the double-blind study, the physician must not know if he's doing, the patient must not know if it is the procedure, and also she must feel the same something like this, the same stuff in the vagina. That so you will never do this.
Yeah.
Never. It will. You never going to happen. You will have an evidence-based number two, and I think that we are doing things correct in that way. When something is not working, if you are an honest person, you will not continue to do it. So I am sure that I've been doing vaginal lasers for more than 10 years.
Mhm.
People are still coming, and I'm very known in mediatically on TV, etc. If as I told you, I have 500 people, women with vaginal laser each year now in my clinic. So if there were 50 very upset with this, people would know.
Yeah, it would get
Because
out there.
people talks when they have bad results. When there is one or two, it's normal. I told the patient that you will have bad results in maybe 10% or 12, 15%.
Yeah,
But
you may not get the tightening you want or the dryness you want because no
of
science
course,
is perfect.
of course, but 85% of a procedure of 4 minutes done 3 times to be dry or almost dry
Right.
for 2 years is fantastic.
It's fantastic. Yeah. You can't argue with those type of results.
Yes, yes,
And you certainly can't double blind randomize a labiaplasty. That's silly.
it's absolutely impossible to randomize. You can randomize in a certain way vaginoplasty
Yeah.
without perineoplasty. You can do something better if you use, for example, sexologists
Right.
with good questionnaires before and after. I have done it. The first paper I did, I done it, and you can reach some kind of, but number three,
Right.
double blind is impossible.
No, I want to make sure I cover a couple more points. One is that the anesthesia you use for majora, again, I'm going to focus on majora. Are these surgery center procedures, office procedures where you're at, and how do you manage
Okay.
those issues and pain issues also?
All my labia majora, labia minora, vaginoplasty, perineoplasty, anal remove of skin,
Anal skin tags.
NSQ tags, all of them are done under local anesthesia without sedation.
No IV?
No IV, only local anesthesia. And they love it.
Yeah.
Sometimes you have what I call a window of no anesthesia in some place. The patient will move like this. You put more anesthesia, and that's it.
Yeah.
After the surgery, they love that they didn't have any extra medication. They stay one. I give them oral analgesic before the surgery, oral analgesic immediately after the surgery, and they go home. And the afternoon, I never, an advice, I never do surgeries in the afternoon. Never.
I understand. They get vasovagal.
Yes, because as you know, we don't want a patient bleeding during the night. So I try to do no more than 2 patients each morning. Sometimes they are very extremely, you get tired with that, those surgeries. With 3 is really too much. I do 2 patients. Sometimes I do 1. If there is 1 patient with labia majora, labia minora,
You
labiaplasty,
can only handle 1 patient.
I handle only 1 patient. And the afternoon, I order them to stay at bed. I hope that they stay in bed for if the surgery is bigger, not a simple labiaplasty, not necessary. But the day of the surgery, bed, and I give them some analgesic that are with this in Chile we call tramadol. It's like morphine.
Tramadol, yes.
Yes,
Tramadol.
it's fantastic. It's very good, and it's absolutely enough. I have more than one. I think that in 4 years, I have more than 1,000 surgeries done under local anesthesia in my near 1,000, and never one patient has come the afternoon of the surgery saying that they can't afford the pain.
Right.
No one.
Right.
No one.
Yeah,
All of them, you give more oral analgesic is enough. When a patient has too much pain, you must suspect something,
right.
perhaps an hematoma, for example, I think.
Yeah, we've done nothing but local anesthesia, and that's the only thing I've taught since 2005. And I agree with you. It's exceptionally safe, lower complication rate. And now I'm not sure if this is available in Chile yet, but with the use of liposome-coated bupivacaine, we call it, the brand name in the United States is Exparel. It's basically Marcaine, and we inject it, and it lasts 3 to 5 days. So they have zero pain for at least 3 days.
Fantastic.
And
yes.
hey, if it's available, go give it a try. Exparel, Exparel. And it's made by Pacira Medical. I'm kind of revealing some of my top secrets, but that's what we do for
Yes.
deep vaginoplasty. And we use Exparel. They have no pain for days.
Well, I think
they
that
can fly away.
Vaginoplastic is not too much pain. Really, the patient, the pain is, I would say, maybe 4 from 0 to 10. No more. On only the first day, I put them also. I let them gauze into the vagina. They remove their own gauze the day after. I see the patient 1 week later, and then the 6 weeks after the surgery.
Right. That's for vaginal. Even majora, you do the same?
No, the majora and minora, the same. When the patient is not from Santiago de Chile, we do a video call the next week. And I also have patients that come from other countries to do the surgery with me, and I try them to not to travel at least 5-6 days after the surgery.
Well, Jack, you've been
I want to say something.
Sure.
A parenthesis for all the people that have seen this video. I'm doing these surgeries from 20 years, but the last 4 years I turned all 99 of my practice into in-office surgeries and with local anesthesia. And my gurus for this, the people that I look and I decided to turn this was Red Allinson. Yes, you
Thank
absolutely.
you.
One was you, and the other one was Michael Goodman.
Yes, Michael was my student in 2009 or so. I taught him all my local anesthesia tricks.
I saw you. I follow you since I began with this. And one day we have a chat together, you and me. I don't know in which country. I don't remember that. And you told me, "Hey, I knew that you was doing everything with local anesthesia. And one day after seeing all your work, I talked with Michael Goodman, and he said to me, I don't remember when was the last time I took a patient to an hospital. All my surgeries are like this. And during the pandemic, I did this clinic where I work. The inauguration of Gyn-Esthetica was in June 2020. Can you imagine that?
Wow, that's during the pandemic.
Absolutely during the pandemic. And since the day one, we were overbooked. Incredible.
Wow.
Why? Because people wanted to do something with their times. And
Right.
yes, they had the money, they have time.
They couldn't vacation with their money.
No, they couldn't vacation. And also my country give to the people a lot of money because they allowed them to retire money from their retirement profit.
Oh, okay. It's like a stimulus with their own money.
It was a very bad decision for Chilean economy, but very good for me. And people came here, and during the pandemic, I had systematically 15 surgeries every month.
Wow.
Every month. And but I wanted to say that one of the big influence to do surgeries with local anesthesia is red alisol.
Oh, well, thank you very much. That's very kind of you. And I know I've taken up so much of your time, and you've been very generous, but I wanted to close on how did we connect? How did you know about me? Was it in Vegas when we first got connected, and then over the years, just our friendship?
No.
How did you hear of me?
There are names that, as you say in USA, that rings your bell, no?
Mm-hmm.
And Red Allinson, you was very famous, known. When you hear about cosmetic gynecology, and I see some Red Allinson, you was always there. And you had also a Facebook. And
Right.
we became, I don't know if you send me to friendship.
I sent you an invite.
Yes, I don't know if it was you and me.
Yeah.
But one day you wrote something about the labia majora.
Right.
And I wrote, this is 10 years ago. No, 10 years ago. And I wrote you, "Hi, Red, this is Jack Pardo." We never talked before. You talk about labia majora, and I wrote a paper about labia majora in the Cosmetic American Journal. Oh, send me the paper. You forgot, but I sent you the paper. I will send you again. And this began our friendship. And then we meet in the, I think
it was Vegas at the
but in Vegas
meeting and ISCG.
In Vegas we met. We met. But our friendship, I think it began after that, and then a lot of meetings, a lot of songs. You always
my favorite.
You always tape me when you always are there when I sing in the last.
My favorite one was your singing in, I think it was Madrid, because there were flamenco dancers, and then you got up on stage and just blew all of us away.
In Madrid, I sang only Frank Sinatra's songs, and also I was with Tuxedo, so
we were all dressed up.
When you sing Frank Sinatra's song, you must be on Tuxedo.
I remember that. We were all, most of us in America had never heard you sing. And so when we were all there, we were just staring at each other. Miklos and I were just going, it was awesome.
How can a Chilean can sing like Frank Sinatra? Is impossible.
And now you have an album to prove it.
Oh, yes. Now I have an album. It's called Miss Divas. It means My Divas. It's an album that I dedicate to women. Why? Because there are 11 songs that only of famous female singers like Whitney Houston, Barbara Streisand, Amy Winehouse, etc. And I'm working in a new project that I will do a mini album of singing only Frank Sinatra's songs.
Oh,
The next
I'll
project.
definitely get that one.
That this is my specialty. The other thing that I done it was because I didn't wanted to do a first album with something so typical than me singing
Right.
Frank Sinatra or Elvis or something like this. But because this is very new, a man singing women's songs.
Yeah,
This is
yeah.
what I did is original.
Hey, so Jack, I've been traveling the world quite a bit this past year, and so many young doctors are wanting to get involved in this and really want to get trained. I remember the Antigua meeting had 550 OBGYNs. Can you believe
Yes.
it? I couldn't believe it. And then Tijuana had a couple hundred. What I was saying was there are so many young doctors who are wanting to enter this, and their advice is, how do I do it? So before we close, this is the last thing, is what's your advice to the young doctor who is in their last year or so of residency or in their first year or two of practice, who suddenly says, hey, this is kind of fun. I want to look into this. What would you advise them?
No, I will be very sincere with you with this question. And I don't think it's a good idea that all these young doctors, gynecologists, want to be cosmetic gynecology, because someone has to have the intention, the heart to do perinatology, to do deliveries, to do it's very disappointing that, I don't know, all the new gynecologists want to be cosmetic gynecology. I think, as I told you, that this is an area that must be done by expert. And the expert for me is the urogynecologist. I would say to a young doctor, be first a good vaginal surgeon.
Be a good surgeon.
You must learn how to do an incontinence. Why? Because if a patient comes to you and you don't know how to do a mid-urethral sling, you will offer a laser to all the patients, even the ones that are very severe, and you will have bad results.
Yeah, and the only tool you'll have is a hammer. You don't have a wide selection.
Exactly. In the other hand, what's happened with the urogynecologists that don't believe in us? They offer sometimes surgery to patients that have mild incontinence that would be excellent candidates for laser or radio frequency. Now, to see cosmetic gynecology only as to do labiaplasty is to have a vision like this. I think that we must have a wider vision, and have an approach more holistic to the vagina and to woman.
That's why you personally do the Urogyn plus hormone management. You're taking care of the entire spectrum.
Yes, I do hormone replacement treatment. I'm not overbooked totally, so I'm still doing annual control of my patients. I ask for mammographies, etc., but most of women that don't have stress incontinence or problem of the labia, they come to me because I believe that they need hormone replacement treatment, estrogen, sometimes progesterones, and testosterone. I believe in testosterone. I think testosterone is an incredible tool to have a good quality of life for women. Incredible.
Right. It's very underused. I mean, it's so important for the quality of life and disease prevention.
Yes.
Lowering your risk for even breast cancer. It's crazy. People don't know that.
They don't know that the papers support the use of testosterone, and even you have less disease. breast disease with testosterone. And there are two doctors, two breast surgeons, oncologists, female, that are sending me sometimes women for testosterone pellet implant, and also for vaginal laser. They
Right,
send
right.
me. Yes.
Now, okay, so put your thinking cap on and now address the very experienced cosmetic gynecologists, those who've been doing it a lot, have many years below their belt, and they think that they know everything and they don't need to learn anything else. But so now the question is, where do you see the future growth? What area? I'll tell you mine, but I want to hear your idea, and where do you think they should pursue in the future? Because if they stay static and don't pursue any growth, they're going to get left behind by the new aggressive young guys. Now,
Yes,
yeah,
I think that
address the established doctor.
I don't know if you understand, but I think we talked about before the break we had, that I think that this subspecialty must be under, mostly under the urogynecologist,
Yes, I get it.
and maybe working with others like specialists in menopause. But I don't feel comfortable that in, for example, urologists doing Labiaplasty,
Mhm.
or even plastic surgeon. You know, the most bad Labiaplasty that I have seen in Chile, for example, has been performed by plastic surgeons, not
Because of all
gynecologists.
the wedges.
I think this is the way that someday cosmetic gynecology will be part of the learning of all gynecologists and obstetrics, but part of the knowledge, but must be done for specialists. We need specialists for all the specialties.
Where
Yes.
should the established cosmetic gynecologists put their dollars into learning? Is it learning how to do lipo, fat transfer, learn how to do stromal vascular fraction? Where do you think the next growth region is?
It's easy to learn lipo, abdominoplasty, and I never been there because I want the plastic surgeons respect me
Mhm.
that I own the vagina, but I think they deserve that I respect them, that they own the the liposuction.
Right,
So
right.
that's the only liposuction I do is the mont pubis.
Once pubis.
Sometimes when it's something light and when something big, is mostly of them they require another thing, and I send them to the plastic surgeon.
Right, right.
That in Chile, the plastic surgeons are not my enemies in Chile because they know that I don't go into their fields. So I think that plastic surgery is another specialty, and we must
Right.
respect.
I'm much like you. I gave up my liposuction practice probably 13, 15 years ago, somewhere there. And then I left it for my really excellent plastic surgeon friends who would do that. I used to do half of the tummy tucks with them together. And I got too busy with my GYN surgeries. And so, but I'll share with you where I think the next growth phase is, and you mentioned it really quickly, anal skin tags. No one knows how
Yes.
to do it. Everyone avoids it. Colorectals run from it. General surgeons run for it. Plastic surgeons run from it. Urogyn's run from it. I think us new cosmetic gynecologists are the ones who
I will
have
tell
the
you
skill.
my experience with anal skin tags. I began to do this on my own. I decided to do it, and I began to offer to all of my patients. But when I did this clinic, Gyn-Esthetica, I had a friend that he's a coloproctologist, and I encouraged him to take this. And when it's a very simple anal skill tag, I do it. But mostly of them, they have a mucosa component made. Sometimes they have a vein, an hemorrhoidal vein. And mostly of them, I send them to him, and he's doing beautiful local anal surgeries here, even internal hemorrhoids with local anesthesia. Because when you begin with this of the local anesthesia, you go step by step doing more things. And now in my clinic, I send them to him. And then I lose some of them, mostly of them, but I'm happy that the clinic, my center that I own, have these specialists. So in this case, I think that if there is something very, very small, okay, you can do it. But if there is something bigger with an hemorrhoid, it's better than he do, because he will be better prepared for the complication. Also, when we talked minutes before about liposuction, if we went to this world of cosmetic gynecology, is also to avoid complications. And lipo has complication. Abdominoplasty has more complication. You can have a embolic thromboembolism, pulmonary thromboembolism. You can have so if you have this beautiful specialty as cosmetic gynecology that in 99.99% of cases you don't have a big complication, why you go to liposuction or abdominoplasty? I will not do it. I respect other people that do it. I don't want to do it.
Right. Yeah, I'm pretty much there with you, similar. But I do feel that most of the anal skin tags we can handle, because no one can find anyone to do it. I have one graduate who gave up pretty much her Urogyne practice in a major city in the US, and now has 3 anal skin tag clinics, just doing external anal skin tag.
3
clinics, one across the one in the southeast, one in the Midwest, and one in, I mean, it's spread out, and she flies to these places and does nothing but anal skin tag, external anal skin tag for cosmetics. And
you know what?
She is doing so good.
Tomorrow, in Wednesday, I have the meeting with the social media people.
Yeah.
And we'll tell them this.
You got to do that.
I will advertise more about this.
Yes. I have created a whole section on my gynflix.com to train my subscribers if they want to learn how to do anal skin tags, even the ones that are covering up all 4 quadrants. We call them cauliflower lesions. So we've coined cauliflower lesions treatment.
Cauliflower.
Yes. And so I think that's one of the most viewed sections on Gynflix, all my anal skin tag videos. And I think, get that onto your social media, because you will be the only one in Latin America who specializes in it.
Yes, but this is something that happens always. Most of the proctologists, they do the surgery of the internal hemorrhoid, and the aesthetical anal point of view, they don't see nothing. They don't care about it. And women, and also men, they want to have a beautiful anus.
Yes.
And this is very important for them. In my clinic, the proctologists do at least 1 or 2 men every week in anal skin stacks and little hemorrhoids, and we must care for this. There are people that they need this.
Yeah, I think so too. I think it's an unmet.
But I will advertise more.
Yeah,
I will advertise more about it.
Good. I gave you one idea for your social media.
Yes. I will
Well,
do
Jack,
it.
I really want to thank you for spending so much time with me. It's great to reconnect and get a historical perspective on where it all started, because you were there right at the beginning. I mean, you were there, one of David's earliest grads, and you even influenced Miklos and more to get trained, and you started doing all the publications that all
Yeah.
of us Americans really didn't want to do. We didn't want to publish it because it was our
Well,
secret.
Brett, for me, it's the really, really an honor that someone like you, that you are one of the pioneer, as considering me to give my experience to your public. So I am proud. I am happy to have a conversation with you. Like always, we
It's
always
great.
have very good conversation.
We always have a
And
good time talking.
yes, this is one conversation that will stay recorded for forever. So
Yes.
more pleasure, even more pleasure. Thank you very much to you.
Thank you very much, Jack, and go have dinner. Take
Bye
care.
bye.
Bye-bye.
See you.
Bye-bye.